Hello and welcome again. So this is the second lecture of the maternal medicine lecture series, and today we are going to talk about iron deficiency anemia in pregnancy. So basically, that's a very common topic, and I know most of you probably know a lot about this topic already. That I would say we may not add much to what you already know, but we're trying to just emphasize on few things related to iron deficiency anemia, especially because it's really common. I would say like 40% of women actually in pregnancy have some sort of anemia. And as we all know, its most common cause is iron deficiency anemia. So today we are going to discuss this topic and just highlight some few things that I would like to be sure we just give it enough emphasis. So first thing before we start, I would like to just refer to an important point, because when we treat iron deficiency anemia, we always think about, just that we are preparing for labor. So basically we want to correct anemia if it's present, just because when this lady goes into labor, we have some buffer or just increasing the tolerance of this lady to any postpartum hemorrhage, which commonly happens, which is not wrong. But it's important to also understand that it's not just that we need to correct anemia before she gets into labor. Just the fact that she's anemic during pregnancy can bring a lot of issues. Even maternally, regarding quality of life, anemia can cause shortness of breath, can cause really tiredness, fatigue. And this is really significant, especially when a lady is already pregnant and she has baseline symptoms going on. So that's important. The other thing is, as you know, the presence of anemia itself can increase the risk of some obstetric complications like fetal growth restriction, like preterm labor. So we have to be more proactive in correcting anemia. I'm not saying that you have to be really aggressive, but I mean, you have to make a plan and be sure that the plan is working and that you correct anemia as soon as you can. So let's get started. So first thing, basically that's a straightforward topic. So here we are going to discuss how to diagnose iron deficiency anemia, and once you diagnose iron deficiency anemia, how you're going to treat iron deficiency anemia, straightforward. So basically, for the diagnosis of iron deficiency anemia, it's not complicated, it's not difficult. I would say we are screening everyone. So any pregnant lady at the booking appointment is checked for FBC or full blood count. We do that again at 28 weeks because we know there is a lot of physiologic changes that can happen in pregnancy and there's increased demands of nutrition. So we would like to be sure that she continues to do okay at 28 weeks as well. So any pregnant lady should have an FBC to check on anemia at the beginning of pregnancy and before the beginning of the third trimester, straightforward. So if there is any issues, you can always pick them up very quickly. The other thing is, anemia is an issue even after delivery. So the fact that we sometimes just miss anemia after delivery just because we think the lady delivered, she's doing okay, she can go home. But you don't want this lady to go home with a low hemoglobin, with a significant anemia. Just because she looks like she's doing fine, because anemia is physiologically corrected, we know that, but it takes a long time for a woman to restore her hemoglobin, restore her iron stores. So, and during this period, which may take 3 months or more, she definitely would have issues with symptoms like being tired, having shortness of breath, feeling dizzy, lightheaded. That's significant. That really impacts her quality of life, and she's having a baby, so that's probably more responsibility on her that requires more energy and more tolerance. So I would say we don't screen for anemia immediately after delivery for all women, but you should check within 48 hours, which is basically the time she stays in hospital after she delivers her baby. If you think she lost more than 500 of blood. So at the time of delivery, if you think that this is estimated blood loss, regardless if you give transfusion or not, I mean, it really depends, but if you think her blood loss was more than 500 milliliters, then you should check hemoglobin, typically in the morning next to delivery, but it's okay within any time during her hospital stay, which is typically 1 or 2 days. The other indication is if the patient already had anemia at the time of pregnancy that was not corrected. For some reason, we were not able to correct it enough before she goes into labor, or if she was discovered to be anemic late in pregnancy and that was not corrected. So if that's the situation, you should definitely check for FBC and be sure that she's not anemic, or if she's anemic after delivery, you need to have a plan and action. Really depends on how bad the anemia is and how her symptoms look like to decide what you want to do before she goes home. Otherwise, she will continue having symptoms without being checked or being fixed, basically. So that's very important. There is always a debate about universal iron supply. I mean, basically, in many places in the world, they just give iron to all pregnant ladies. In some places, they prefer to give iron after the first trimester, for sure, because, you know, in the first trimester, she will be really struggling with stomach issues, vomiting, even up to hyperemesis, and iron really doesn't make things very good. So they recommend that we start iron after second or after the first trimester. But to be honest, I mean, the recommendations now do not say that we have to give iron to everyone, because basically you're doing a good screening, you're doing tests for like who's having iron deficiency anemia. And we typically check for ferritin as well. So you don't have to give iron to everyone because to be honest, I mean, iron really cause side effects. And a lot of women will really have hard time being on iron throughout pregnancy. And you don't want to really cause them a lot of side effects for no reason. We know that like iron requirement during pregnancy increase, but you can always, you know, recommend better diet, nutrition, tell them what are the best sources of iron. I mean, the common sense of the advices that you typically give for pregnant women. And then if they actually just supply themselves with enough iron from diet, which is something that is easy to achieve, then they don't have to have iron supplementation, which makes sense. If you don't have to give it as a medication, I mean, if they can get it through diet, then there's no point. So let's talk a little bit about how to diagnose iron deficiency anemia. So as we said, she will come at the booking appointment. You will do an FBC, check how things look like, and see how hemoglobin level is. So to be clear about things, we know that for physiologic reasons, the level of hemoglobin that we use to diagnose anemia is different in pregnancy, it's a little bit lower. So if you're doing that at the booking appointment as a first trimester, it's 110 in gram per liter. If you're using gram per deciliter, then it's 11. That's the first trimester. In the second trimester, it's 105. And if you're doing that as a postpartum, it's typically 100. Sorry, that's a typo. That's 100 basically. So this is the level that you use to check for anemia. So as in the graph, if there is any of these, then like if the level of hemoglobin is less than any of these cutoffs, this makes the diagnosis of anemia. Okay. What else we would like to check on? We know that iron deficiency anemia is a microcytic anemia, which means that we check for anemia and we check for being microcytic, which means microcytosis. And this is extremely tricky. We used to say that the definition of microcytosis or being microcytic in adults means that the mean corpuscular volume, or MCV, is less than 80 femtoliter. Well, that's a common cutoff, but to be clear about things, there is no cutoff for that. There is no cutoff where you say below it, it's a microcytic, above it, it's not microcytic or a normocytic. Actually, the fact is the less or the lower the mean corpuscular volume is, the higher the chance for this to be a microcytic anemia and an iron deficiency anemia. So for example, if a lady has an MCV of 75 femtoliter, this means that the probability of microcytic anemia is 68%. So, opposite side, if you go higher up, and if you say, for example, that the mean corpuscular volume is above 95 femtoliter, the chance of this being a microcytic anemia or an iron deficiency anemia is significantly low. So in other words, a lot of people, a lot of labs just use 95 femtoliter as a cutoff. That's because if it's anything below 95, the sensitivity for microcytic anemia is 97%. I don't want you to just get confused, but what I'm trying to say is, if we use the usual cutoff that we think it is in adults, which is 80, we will likely miss a lot of patients. But using a cutoff of 95, which I know it's high, it's increasing the sensitivity, which means that you are unlikely to miss any case of iron deficiency anemia. But you know that you are likely to include a lot of women that are not microcytic. So to make things clear, what I'm trying to say is, as long as the mean corpuscular volume is less than 95 femtoliter, you still should think it could be iron deficiency anemia. It's not 80, it's 95, which I mean is a little bit different than the classic teaching for microcytic anemia. So I would say if you get any of these levels of hemoglobin less than 11 or less than 110 in the first trimester, for example, and you have a mean corpuscular volume that's less than 95%, you still should think of iron deficiency anemia because it's still the most common cause. So other markers that you can check in the FBC that may help you to make the diagnosis, sometimes a hypochromia, because we know it's a microcytic hypochromic anemia. So the hypochromia is basically the mean corpuscular hemoglobin concentration is the indicator of hypochromia. And if you use cutoffs, for example, I mean, you need to always check the cutoff in pregnancy because these numbers are different. For example, in the second trimester, it's 324 to 352. These levels are available. You can find them in the labs themselves, or you find them online, or like using a website like Perinatology. These things help you to check for the levels if they are not provided for pregnancy in the lab. But I would say it's another indicator, but we still do not, I mean, typically have to use just this indicator of the hypochromia as the only way to diagnose iron deficiency anemia, but just added some information. The other one, which is very important, is an isocytosis, which means that the RBCs are inconsistent in size. There is like different sizes of RBCs indicating process of synthesis of RBCs. So this is indicated by something called RDW, which is the red cell distribution width. So when the red cell distribution width increases, this typically means that there is an isocytosis, which is another sign of iron deficiency anemia. Again, not saying that you use that essentially to diagnose iron deficiency anemia, but I mean the presence of these markers, I mean, especially if you have a microcytosis, it's not typical. I mean, like as we mentioned, that you have a mean corpuscular volume that is less than 95, but still high, is like 90 something, which makes you feel like, oh, maybe it's not microcytic. Then the presence of hypochromia, the presence of an isocytosis really adds to your diagnosis. As we said, it's expected in iron deficiency anemia to have hypochromia and to have an isocytosis, which means increase in the red cell distribution width. Okay, so let's say that we did an FBC and we figured out that there is anemia based on these cutoffs, and we figured out that there is microcytosis, or at least it's less than 95 femtoliter for the mean corpuscular volume. Then we say, okay, it could be a microcytic anemia. Again, microcytic anemia has different causes, so you always need to check on ferritin. And to check on ferritin basically means that you ask for serum ferritin, straightforward. So typically for ferritin to be deficient, this means that you will check and you find the levels are less than 30 nanogram per milliliter. If you see a microcytic anemia with ferritin less than 30 nanogram per milliliter, that means that iron deficiency anemia is 90% the likely diagnosis. Again, this is like how we diagnose. So as you see, it's typically that you need to have an FBC to start with, and then you are likely to ask for ferritin level in pregnancy. And just to be aware, I mean, just a side information, but it's a physiologic thing, but it's good to know about it, is mean corpuscular volume typically increases in pregnancy as a part of the physiologic process. And it's a small increase, it's like 4 femtoliter, but just adds to the information that, you know, it's still tricky to use mean corpuscular volume in pregnancy as the only indicator of iron deficiency anemia. The other thing which is very important, just remember that in mild cases of anemia, mean corpuscular volume may not even be affected, may still be normal. So that adds also to the information that mean corpuscular volume is not like a pathognomonic, sharp way to diagnose iron deficiency anemia. And this is probably the most important message I would like to emphasize on when we talk about the diagnosis of iron deficiency anemia. So in summary, again, what you need to do here is to do an FBC, check hemoglobin level, check the other markers of iron deficiency anemia, and it's very likely that you will request ferritin. And just bear in mind, anemia could have multiple causes. So even if the lady has another reason why she's having anemia, she still may have low ferritin, which represent iron deficiency anemia, and you still need to fix that. Okay, so let's get started with the next thing here. So one last thing before we jump out of diagnosis, which I think it's very important to think about, is when ferritin is not suitable for diagnosis of iron deficiency anemia. We know that ferritin is an indicator of iron stores. So it's a very good way. I mean, it's a classic traditional way of diagnosing iron deficiency. But the problem here is it's also an inflammatory marker. So if a lady of this patient has any reason why she's having an active inflammation right now, acute inflammation, like she's having infection going on right now, that's a problem. Or if she's having like some sort of chronic inflammatory disease, that's another problem. If she has any sort of hepatocellular disease that is significant, I would say, or if unfortunately she's having malignancy. Just bear in mind these three things: inflammation, malignancy, and hepatocellular damage. These three things really elevate serum ferritin for reasons not related to iron deficiency. And this may really misinterpret your results. So if you think she's having any of these ongoing processes or any ongoing diseases like this, the best way is actually to use another alternative, another marker, which is called transferrin saturation. So transferrin saturation, another blood test, typically if it's less than 12%, this is abnormal and you can use it to diagnose iron deficiency anemia. So just bear that in mind, because you really don't want to do a ferritin and you figure out it looks normal just because it's deficient, but it's high due to other reasons. And then you say, oh my gosh, that's not iron deficiency anemia. And then you can imagine how much, or like the effort you need and how many investigations you have to do to actually find out why she's having anemia if it's not iron deficiency anemia. So just bear that in mind and just always think if ferritin is appropriate for those ladies to be tested. So let's go for the more important part, which is actually treating iron deficiency anemia. So as I mentioned earlier, we always think about iron deficiency anemia as a problem to correct before the lady goes into labor. And we always like to optimize her hemoglobin before she goes into labor because we are worried about postpartum hemorrhage, which is okay, but I always like to think about the other risk factors or other risks, basically, of anemia. So during pregnancy, as long as you're keeping this lady anemic, she may have symptoms. You put the baby at increased risk of preterm labor, low birth weight, and of course, her immunity is not going to be perfect and it's high risk of infection. It's not only that the lady is not having good hemoglobin to start with if she has bleeding, actually anemia itself increases the risk of postpartum hemorrhage. So it adds even to the situation of being in postpartum hemorrhage. And of course, after she delivers her baby, she is still at high risk of infection, and she definitely at high risk of depression. Just bear in mind other things. For example, iron itself, or the presence of iron deficiency anemia, has its own problems. Even if it's not, I mean, if iron is deficient, even if she doesn't have iron deficiency anemia, that would affect her cognitive capacity, affect her energy, and even may have effect on like the intellectual functions of the brain of the baby. So this is important to think about when you decide on treating anemia. Just be more proactive on treating. That doesn't mean that if a lady comes with a hemoglobin of 94, that means that you have to give her blood transfusion. I'm not saying that, but I mean, at least you have to be proactive. Try first line. If it's not working, then go ahead and try the second line. Be sure that you are not given a treatment and you're not following up. It's like, okay, you're anemic, I'm giving you oral iron tablets, and then the patient goes home and takes it and you don't follow up, and and eventually figure out that her hemoglobin was never corrected, either because for some reason it's not working for her, or other reasons like she's not compliant to start with, which is, I mean, it's very common with oral iron. If she's taking it as a treatment, that she will take it, have GI upset, and she will not be happy with it, and she will stop taking it, and she will not tell you because she doesn't want you to tell her, okay, you're not doing the right thing, and then force her to take the medication, or just put pressure on her and take a medication that she doesn't like. And that's important. That's important to share information with the patient. Tell her why we're treating your anemia, and actually giving her awareness of the side effect. I mean, even for her to understand that if she's having shortness of breath, if she's having low energy, that could be part of it, could be related to the anemia, not just pregnancy. And at the same time, that this could have sequences on you and your baby. So very important to think about. So if you find iron deficiency anemia, what are your options? Absolutely oral iron. And when we say oral iron, it means any form of oral iron. It's tablets, liquids, sachets, whatever. But we know that the tablets are probably the most common forms. We know that ferrous sulfate is typically the most common or the most preferred one for correction of iron deficiency anemia. So typically the recommended regimen is to give ferrous sulfate 200 milligrams orally, which typically contains 65 of elemental iron. You sometimes can give it on divided doses if that's possible to reduce the side effects of like a high single dose, if that's possible. It's important when you give the patient the prescription for iron is to give her some instructions, very important, to be sure that you don't waste her time taking iron for no reason. This means she always should take iron on empty stomach, which means, I mean, to make it easy, because she typically takes it once a day, is to tell her just take it at least more than 1 hour before the next meal. So not after the meal, of course, it's not enough, but before the next meal. If she's taking like 3 meals a day, then ask her, okay, if you're eating your lunch now, then when is your expected dinner? Okay, your expected dinner is going to be, say at 9 p.m. Then you ask her, okay, then just take iron anytime before 8 p.m., but not like after lunch. It's basically that you want to space it so it's away from the previous meal, but at the same time give it some time to be absorbed before the next meal is taken. So more than 1 hour before the next meal is when you want that. If she can't arrange that, or like eating multiple meals a day, the easiest way is to say take it at night before you go to sleep. But be sure that she's not one of those who like to take a meal just before she goes to sleep. So I mean, you can chat with her, just give her the idea and she can make the proper arrangement for herself. The other thing, shouldn't be taken with tea, shouldn't be taken with milk, straightforward, not with tea with milk, of course, same thing. And it's advised to be taken with vitamin C, so basically like some orange juice or so. It helps absorption of ferrous to start with. And there is a lot of preparations that actually give iron along with folic acid, along with vitamin C to help the absorption, that's fine. But I would say, just be sure that she takes iron in the correct time and that she's taken iron not with other things that interfere with absorption. That's very important. Okay, it's important, and it's a common rule, as you know, just set expectations. So if the patient is aware of what she's expecting, then that increases her chance not to stop the medication. Straightforward. Which means that we expect that the medications like this can cause side effects. The most common side effect, as we know, is GI upset. Feels just, unwell in her stomach, start with. That can goes into nausea, vomiting, and of course, it causes constipation and dark stool. A lot of doctors actually prescribe laxatives with iron just to help just easing constipation. And always remember, a pregnant lady is prone to constipation to start with. She has baseline constipation, which is caused by the effect of progesterone on the bowel, making like bowel relaxed, and they are at higher chance of being constipated. So always ask for or advice on hydration, advice on fibers. And it's okay if you want to prescribe a laxative, hopefully a soft laxative, not like a strong one, at the time you're prescribing iron to help ease things a little bit. But this should be set as an expectation. And the reason why you're setting expectation is she is expecting the side effects. She's not worried, nothing. But again, I mean, if she develops the side effects, there is a good chance that she will stop the medication. So you should always give her this information. If it causes you side effect, just let me know. Then we can do things to help avoiding these side effects, or at least reducing these side effects. It's important to tell her that, so she's reassured that if the medication is causing her side effects and you told her that it's important, that she's not worried that you will force her to be back on the medication without doing anything else. And then she will never tell you. Straightforward. So the other ways, I mean, if she tells you that she's having side effects, is you can always use a lower dose. It's okay, especially if it's early in pregnancy and you have time to correct her anemia. It's okay to use a lower dose, or to use an alternative, like alternate day regimen, which means a day on, a day off. Just give her some, break from the medication and help stomach to be in a good shape. The other thing which I always like to emphasize on is iron polymaltose. So this is different from the ferrous sulfate preparation. It's a different preparation, but it's very known to be better absorbed. That's one thing. And the other thing is causing definitely less GI problems. That's very important. So if you think that she is really struggling with the iron sulfate or the ferrous sulfate and there's nothing else helping, you can always shift her to a different preparation. And iron polymaltose, can also come in like different preparations, including the liquid form, which many women just prefer. So as I said, just keep good communication. Just be sure that you communicate with the patient about side effects. Be sure that she's compliant and you have a follow-up plan in place. So how to follow up on if you start her on oral iron? So the first thing is you always like to check hemoglobin, but when you check hemoglobin doing FBC, you should give the medication some time to help. So basically, you can repeat that after 2 weeks or so. The expectations, if oral iron is well absorbed and it's really working and it's really iron deficiency anemia, that you will expect her hemoglobin to increase by 1.2 gram per liter in a day. Which means, I mean, he definitely will not catch the 1.2. It's very hard to catch. That's why you give it some time to see the difference. And if you give it like 3 or 4 weeks, you're expecting a change of around 20 grams per liter, which is actually a real correction of her anemia. That's a difference. I mean, not like enough difference, but that means that you're heading the right direction. But you need to keep her on iron for actually a longer time. So again, you have to repeat FBC and see how she's doing after 2 weeks or so. Because if there is no response, you have to investigate, you have to make a plan, straightforward. So if things look right and you think her hemoglobin is corrected, you don't have to keep following up. I mean, you can repeat it just close to the time of delivery or so, I mean, depending on the numbers. But you can keep going with oral iron as long as it seems to be working and she seems to be compliant. Typically, you should continue taking iron for at least 3 months, which is the expected time for her to actually get her iron stores corrected. And it's typically 6 weeks after restoring normal iron levels. So it's either this or that. I mean, it's probably going to be a comparable time. But I mean, typically, if she's pregnant, we are likely to ask her to continue taking oral iron for 3 months after she delivers her baby. So that's an easy way to just remember it and give instructions about it. What if levels are not getting better? What if you are giving iron and you checked after 2 weeks or so, and it's not changing? There's a lot of reasons why this could happen. The most important, the most common of them is probably poor compliance. I mean, this lady is for some reason not taking it regularly, maybe for the side effects or for some other reasons. So you should always ask and be clear about it and offer help if there is any problem. But again, a woman may swear to God that she really is taking the medication every day. Fine. But in these situations, there is a good chance that maybe just a poor absorption, which means that you should investigate about any history of GI symptoms. You know, some of them are clear, like if she has an inflammatory bowel disease, for example, or a gastric bypass history, or a celiac disease. These things are likely to be obvious, and you will figure out once you ask them about the history. And this honestly should be asked from the beginning. But if you missed it, it's okay to ask them before you give them the medication. Are you having any gastric bypass surgeries in the past? Are you having any sort of like celiac disease, inflammatory bowel, things like that? Some of them are easy to miss, like if she's having Helicobacter infection, H. pylori infection. There's very good chance you're not gonna know. But I mean, in most of the situations, you will likely get the sense of that she's having problems with absorption. And in this situation, I mean, that's easy fix. Then you can give iron through an IV. So that's one thing. The other thing is if she's taken other medications. And again, you can ask about that. And it's easy answer. Okay, it's are you taking other medications? And the most important medication we're asking about here is proton pump inhibitors. So those act basically on the stomach, and they reduce acidity and reduce the absorption of iron. And if she's taking this medication, then she's very likely not gonna benefit from oral iron. The other thing and the last thing, which is, very uncommon, but you should always consider, is that she's having a microcytic anemia, but it's not really iron deficiency anemia. And the reasons for that, I would say probably the most common is thalassemia. You can make a guess, based on race, but in a lot of places, most of places, we like to check on that at the beginning of pregnancy, especially if a lady is a high risk of having thalassemia. And you can make a guess because there's typically a family history. But still, if you have a strong doubt on thalassemia, it's okay. You can always do a hemoglobin electrophoresis. But the thing is, you typically don't go there unless you really tried everything, because if you tried oral iron and you have doubts about if it's absorbed or there is compliance, you can always try parenteral iron. And if IV infusion of iron doesn't help, then it's very likely that there's something else going on. But thalassemia is easy to exclude. Other reasons like sideroblastic anemia, like lead poisoning, are very, very uncommon. Lead poisoning used to be in the past when they used lead in painting, but seriously, it's not to be expected really in these kinds of cases. Anemia of chronic disease, can cause microcytic anemia, but absolutely there's a chronic disease. So you will know from the presence of a chronic disease. So again, you can always, when there is no enough response to the medication, to the oral iron, and you think it's not a problem of compliance, then you can always check by asking about history, medical history, surgical history, if she's having any surgeries, and history of medications. And based on these three things, medical, surgical, and medications, you can tell if there is an obvious reason why she's not responding to oral iron, or if it's not clear, but you still think it's iron deficiency anemia. Either way, if she's not responding to oral iron, the next step will be to give iron as an IV infusion. So as we said, if a woman did not respond right away to oral iron, so we check after 2 to 3 weeks, if it's not responding, then done. You're not giving longer time to try, it's done. Unless you think that it's basically related to some non-compliance, like some GI symptoms, and you can fix it. You can change her mind about the compliance, or you can use a different oral formula that you think is probably going to be more easier for her to take. That's fine. But if you think she took oral iron, no response in 2 or 3 weeks, don't wait for, just move to iron infusion as a second line. So IV infusion typically is given to those who do not respond to oral iron, obviously. But sometimes we have to do it as a one action. It's like a first line if we think we are running out of time. So simply, if the lady is more than 34 weeks and her hemoglobin is less than 100, which is 10 gram per deciliter if you're using a different unit. So if she has these two factors, not one of them, two of them, so hemoglobin is less than 10 or less than 100, and she is advanced in pregnancy, so it's close to time of labor, she's more than 34 weeks, and she can be in labor within weeks, then I have to fix that very quickly and use IV iron. The third situation is if she's having significant anemia. Basically, her hemoglobin is less than 70. And in these cases, you may argue about transfusion, blood transfusion, but basically some would prefer to give a blood transfusion if it's less than 60, or if it's less than 70, but she's having significant symptoms, which means that she definitely needs a quick correction of anemia. But if she's having anemia, severe anemia, less than 70, but she's still doing okay, and she has enough time from the time of labor, you can argue that you can give her IV iron infusion as a line of treatment, or if she doesn't like to have a blood transfusion to start with. Okay, so what do you need to tell? Basically, if you are speaking to a lady and you want to give her IV iron, typically you need to obtain a consent. Because first, there could be an anaphylactic reaction. So you should tell the patient that with IV iron, there's a chance of anaphylaxis. A low chance, but it's still there. And this means that it should be given in the hospital. Sometimes we need to test before we give the iron to see if there is any reaction. And then after IV infusion, we need to observe for some time. So typically, I mean, it may take up to 30 minutes for any reaction to be obvious. So we should tell her about that. So you're really explaining everything and setting expectations. So anaphylaxis is definitely a side effect. Other side effects include general side effects, just feeling sick, having like malaise, having arthralgia. Sometimes you get abdominal pain, sometimes get hypotension, nausea, vomiting. So still some GI symptoms, which is important. I mean, typically they cause general side effects, as I mentioned, which you should mention to the patient in the consent, but they still can cause some GI problems. Typically, the GI problems are less common than the oral form, but they still can happen, So you should mention them as well. The other thing is the preparations. There are different preparations in the IV form, but carboxymaltose, again, maltose, is the preparations that we prefer to use. And that's basically because you can give a large volume of it. And so you don't need, I mean, if you need to compensate for a big defect in her iron stores, then you don't have to give multiple injections. It's typically 1 or 2 injections to start with. Takes shorter time for the infusion and is associated with less side effects. So it's brilliant in different aspects. And that's why carboxymaltose is typically the first choice for us to give as an iron infusion. So after obtaining a consent, which means you should mention all these side effects to her, then you calculate the dose. And calculating the dose, a formula is available in so many places, but it's good to just, get it in your mind. It's not difficult. It's basically that you weigh the patient like any other important IV medication. You just have to weigh the patient right now. You get the weight in kilograms, and then you calculate the target hemoglobin, which means the hemoglobin that you want to achieve, say 11 or like 110. But here, typically the formula, I mean, in the classic formula, it says in gram per deciliter, which means that you say 11 rather than 110. And then you subtract the current hemoglobin. So say her hemoglobin is like, 80, for example, or 8.0. So you have to subtract, so get the number, which is actually makes sense. It's a defect in her hemoglobin. So you get the body weight, you multiply it by the defect in her hemoglobin, which is the difference between the actual and the target hemoglobin. And then you multiply it by 2.45. Then you get the amount of iron that needs to be infused. As you see, these are like the most common or like the famous 3 preparations of iron. So as I mentioned, carboxymaltose, an iron saccharose, and iron dextran. So as we see in this table, actually, each of them in one preparation, they contain different volumes of iron. As I mentioned, carboxymaltose, for example, contains 750 milligrams compared to iron saccharose, which just contains 200 or 300 milligrams. Which means if you, for example, have like you made your calculations and you think you have to give her 1,000 milligrams, this means if you're using for carboxymaltose, then you just need 1+ dose. But if you're using iron saccharose, that means that you need to divide doses and give her like 4 or 5 doses, typically 1 dose every 1 week, which takes some time, which is not ideal sometimes. So I mean, iron carboxymaltose just help with that. You have to give 1 or 2 doses maximum to start with. And similarly, dextran, it's also a big of a volume, so we can just give 1 dose and it compensates for 1,000 milligrams. Of course, for each of these preparations, as we mentioned before, there's a chance of anaphylaxis, which is different depending on the preparation you're using. So for some of those, you have to test before you infuse, while actually for some of them, you need to observe after infusion as well. For example, for carboxymaltose, you have to test before you infuse, and you don't have to observe after infusion. If you test, it's fine. For iron sucrose, for some reasons, we don't have to test and we don't have to observe. So it's the most, or like the easiest to use among all of them, that you don't have to test before infusion and you don't have to observe after infusion. While dextran is, because it's a form that's associated with the highest chance of problem side effects, then you have to test before infusion and you have to observe after infusion for up to 1 hour after starting the infusion. So as you see, I mean, these are different preparations. Obviously, ferric carboxymaltose has a higher hand because it's associated with less side effects and it's a high volume, so you don't have to give multiple doses. Still need to test before infusion, but you don't have to observe after infusion. While iron dextran, yes, it's wonderful in the volume because it has 1 gram inside it and you need 1 dose, but again, it's associated with higher incidence of side effects and needs testing before and follow up after you start the infusion for 1 hour. Iron saccharose seems to be nice because it doesn't need testing or observation, but it's really very small volume that you have to keep, repeating the medication for multiple doses typically to achieve what you want to do. So, as with oral iron, you need to also follow up on IV infusion. And that's basically because you may still a chance that you may start the infusion and then you don't see any difference, which means it's very unlikely for this to be iron deficiency anemia. And then you have to investigate and do your stuff to just see what other causes of anemia could be behind this. So typically you can still check iron or check for FBC. And in these situations, it's a shorter time, so you can check in 1 to 2 weeks. The volume, the same amount of hemoglobin elevations that you're expecting from oral iron in 3 to 4 weeks is actually achievable with IV iron in just 1 week. So you can check after 1 week or so, and then you are expecting the same rise that you were expecting from oral iron to start with. Last thing, blood transfusion. Of course, blood transfusion is the last resort, and I don't have to emphasize, but you know that blood transfusion should always be the last resort in anything, because we know that there are risks associated with transfusion, and we always say that you're transfusing blood. We don't know all what we could transmit through blood. I mean, we're checking for everything that we know, but there are things we don't know. Anyhow, but I mean, it's definitely safe when you're doing it in an appropriate indication. And in these situations, when I say blood transfusion is indicated, it means that you tried everything else and it's not working. And then definitely blood transfusion would make a lot of sense. And you should always go for blood transfusion. So straightforward answer, when we're doing blood transfusion, when all the other measurements cannot be done. That's pretty it. Because I mean, IV iron infusion has really narrowed the indications for blood transfusion, because you can get the benefit in just 1 week, starting to see your patient's hemoglobin is increasing, and then it's really fast enough typically to be a satisfactory option. So I would say yes, blood transfusion if all other measures failed. And as we always say, each blood unit is expecting to increase hemoglobin by, I would say by 100 or 10 grams. Basically, there are things that you should be doing around the time of labor. If you know that this patient is anemic, or you have been treating from anemia and you don't know for some reason how she's doing. So you always check her hemoglobin on admission if she's known to be anemic, not corrected anemia. And if she's known to be anemic, actually anemic, you always like to actively manage her third stage to minimize the risk of blood loss, basically, because she's at high risk of blood loss and she has low tolerance to any sort of bleeding. And of course, for you, practically, just keep a low threshold of treating postpartum hemorrhage. So once you see that bleeding is approaching what it could be a postpartum hemorrhage, just be proactive and start treating vigorously to prevent any sort of bleeding. And as mentioned before, you check her hemoglobin if you think her blood loss has been more than 500, or if her, anemia that you diagnosed during pregnancy has not been corrected. So you check her FBC within 48 hours of delivery, hopefully the early morning of the next day, and then you go from there. And as mentioned before, you should continue giving her oral iron. Even if her anemia is corrected with oral iron, you need to keep that, because even with corrected anemia, the stores take some time to really be repelled. So basically 3 months after delivery would be very reasonable to start with, especially because you know that she will definitely lose some blood at the time of delivery. So that is basically it for a postpartum management. So that was all about it. It's a very light object, but I mean, I would say it's interesting, it's common. You will see that in your practice every single day. There are little things that could be missed while you're thinking about iron deficiency anemia in your practice, but they are very crucial, I would say, for patient care and obstetric care. And thank you so much.